Hi, I am Madison Johnson, and I did my presentation on mobile health clinics for Denisonians living at or below the poverty line, the homeless and unhoused, and transient peoples. Some vital statistics for Denison and Grayson County. We spend almost $14,000 total in standardized Medicare spending per capita in Grayson County. For reference, in Texas, we spend $12,522 per capita. There are 25,286 Medicaid recipients in Grayson County, including pregnant women, children under the age of 5, and high risk special needs children. 18.1% of Denison residents live in poverty, and 20.8% of Denison residents under 65 do not have health insurance. Per a study by the National Law Center on Homelessness and Poverty, published by Lee et al. In 2023, in the US, 2.5 to 3.5 million people are experiencing homelessness any given year. Community assessment. I walked my neighborhood. I live in an urban area in Denison, Texas, that is also in the same neighborhood as the Texoma Family Shelter, formerly known as the Grayson County Homeless Shelter. I interviewed a case manager there and a small business owner in the neighborhood that provides hot meals and food donations to most of the homeless population in the neighborhood. What was generally decided on was that the community needs some sort of mobile health care. Many people cannot find transportation or get themselves to clinics, so having somebody come to them, especially if they do not have a permanent residence, would benefit most of the community at large. Wound care services. Any sort of treat and prevention methods for small wounds or ongoing chronic wounds would help reduce the strain on acute medical services, possibly help reduce infection risks and public health risks. Medication delivery. Most of the community would benefit this, especially elderly, people that do not have health insurance, people that are lacking transportation. Gas prices are high. It costs a lot to get your car fixed. It costs a lot to get a car. So having medications that are delivered to you would reduce a lot of that strain of having to go and get them yourself. Acute mental health interventions. There are programs that exist that take the place of the police force and EMS services for acute mental health intervention. Anytime the police are called for a possible mental health risk in the community or welfare checks, our services or services like us would take the place of EMS and police. Checkups and check-ins. Again, welfare checks. We can take the place of police and EMS. Checkups with the community. We can go find our homeless community, go to them, check up on them, keep a steady rapport, and build up a relationship. And finally, harm reduction services. Harm reduction services are services that exist to reduce the harm that drug use has on the community. These are things like clean needle exchanges, opioid therapy, like Suboxone therapy, opioid withdrawal resources, etc. Harm reduction services exist in large urban areas. There are some in Dallas and Fort Worth and Houston, but mostly in Texas they remain controversial due to the stringent drug laws. I have included an annual impact report from the Texoma Family Shelter. They cannot provide current access to how many people they have in-house because it is protected information. But for their 2023 impact report, they reported that 110 children, families, and individuals were provided with shelter. 176 transports were furnished to residents. 3,670 individual case management sessions were conducted. 647 non-residents were provided food, resources, and referrals, and 31% of those residents were under the age of 18. They helped 25 families with children. 5 residents were studying college-level coursework in residence. 25 residents moved to independent living, and 18,344 meals were served. So the problem this community faces, again, transportation. These communities are not walkable. The infrastructure is poor and it has not been well maintained. Many of the urban areas do not even have existing sidewalks. People are forced to walk or bike in the streets. We do not have bike lanes, and most of these streets are busy with poor walkable intersections. It is not safe to traverse these areas, and most of the larger hospitals are in sister cities or separated by major highways and freeways. Finances. Again, many of these people cannot afford transportation. They can't afford the medical bills either. Mental health. A lot of the homeless population suffers from mental health issues that are direct barriers to them getting adequate health care. And finally, knowledge of assistance. These programs exist to help these people, but they are largely under advertised and underrepresented, so many people are just not aware of their existence. So, prevention, promotion, maintenance, and disease control among the 18.1% of people living at or below the poverty line. This number only includes those who can participate in the census. So our goal population, our target population, is not actually included in this percentage because of their lack of permanent residence. Strengths and weaknesses in the community. There are existing outreach programs within the community, but again, lack of general knowledge or advertisement of these programs results in their underuse. And eventually that results in their underfunding from CMS. The more these programs are used, the more likely they are to receive grants and funding necessary. Large area hospital and many physicians who accept Medicaid and Medicare. However, there is a general mistrust of healthcare corporations by this community, and this leads to long wait times for new patients at the physicians that will accept them and the care clinics that they can get to. This is an urban area which provides many options for clinics or hospitals. However, there are few options for transportation and poor walkable infrastructure. The plan. So the data collected by the homeless shelters will provide a more accurate estimate on possible clients or the supply and demand. We would use this data as a licensed clinic, and we would be able to access it. And we would use it, and we would go to the local medical supply stores for an estimated supply. Once we reach a certain demand criteria, bulk orders are cheaper. Whatever we cannot find in local areas, we can outsource through online med supply stores. We would use existing outreach resources and shelters to build a community rapport. These existing programs have outreach programs that already exist. Using those to piggyback off of and build up trust within the community through word of mouth is the key. We would advertise, provide, promote, and network. We would advertise ourselves. We would show up at community events, give out cards, posters, advertise in local shelters, provide to these people, promote and network with other outreach programs and shelters and any other freestanding clinics that might have a similar idea of what we need to do to be successful. Community involvement. We need to show up and show out. We tell these people we can do something, but we need to show them. We need to prove ourselves so that we can build that trust. And then finally, fundraising. Every nonprofit requires fundraising. So we will have to fundraise. We can use existing programs again, and any sort of existing community fundraisers we can buy into. Some implementation and barriers. So funding. The Texas DHS offers grants to healthcare centers participating in the FQHC incubator program. These grants are actually required to become an FQHC, and once you receive one, you're eligible for CMS evaluation for Medicare funding, which is provided for working FQHCs with a clientele portfolio and then paid based on a prospective payment system or PPS. Policies. So we would be working under Texas requirements for FQHC licensing. These are legal bounds listed under CMS FQHC licensing requirements. The Texas DHHS offers resources for qualified medical service centers, including CMS requirements, coding, and regulatory practices. This website provides everything you need to know, including licensing, building regulations, medical waste disposal, and sharps disposal, etc. So, evaluation. EMS and ED reports would give us an example based on previous year's CMS spending and criteria. We would be able to use these reports post implementation to determine the impact we have had on the community. In a study on nurse-led mobile health clinics by Paradis Gagne et al. 2023, they concluded the following. MHCs result in an increased access to healthcare services, a largely positive level of satisfaction and positive outcomes for service users, reduced risk of healthcare complications, a feeling of inclusion and being listened to, and greater self-awareness of one's health. We found that the MHC enables reaffiliation with the healthcare network and institutional services, for example, hospitals, ED, and medical clinics, enables a more fluid and rapid access to healthcare, in addition to reducing the apprehension and mistrust that people have towards institutional services. Most studies found that MHCs were beneficial to the community overall. And these are my references. Thank you.